have to go ahead and start. All right. Today's topic is very important in the sense that it deals with future of tomorrow, which is infants and children. So I had to make this podcast short and sweet so we can have a meaningful discussion. The special guest today is Dr. George Amanambu from Georgia. At the college level, Dr. George Amanambu started his academic career at the Seventh-day Adventist College, Elisha, Remo, Ogun State in Nigeria. The college is currently known as Babcock University. Dr. Amanambu transferred to the University of North Texas, Denton, Texas, where he earned his bachelor degree of art in business administration. He also earned his master's of business administration with emphasis in finance and administrative management at the Abilene Christian University in Texas. Before transitioning from business to health science, he was a financial analyst with TRW Optoelectronics in Carrollton, Texas for over 9 years. Thereafter, he started another career in academics where he started teaching science and mathematics in high school for over 25 years. While working as a public teacher, Dr. Amanambu completed his PhD in public health with a specialization in epidemiology. Dr. Amanambu has the higher level of teaching certificate in the state of Georgia with varied certification in science, mathematics, and health. Additionally, Dr. Amanambu is a consultant in epidemiology with 2 international nonprofit organizations in public health. Dr. Amanambu is married with 3 children and a granddaughter. So without further ado, thank you so much, Dr. Amanambu, for accepting our invitation to come to Public Show to discuss your study. I know that this particular topic, we scheduled it last year, end of last year, but for some unforeseen circumstances, we were not able to make it. But at the end of the day, you were here with us, for this podcast. Now, I will turn it over to you. Before I turn it over to you, maybe let me turn it over to you to give a shout out. Then you turn it back over to me so that I can finalize what I'm about to say before you start your podcast. Go ahead.
Thank you very much, Dr. Ndukaku. Omelu. I am very happy that I have this opportunity to share my work with our colleagues, and I'm looking forward to continue doing this in the future. My topic is on gestational weight gain and level of education with respect to infant mortality in the state of Mississippi. Because in the last 5 years, Mississippi has had a very high incidence of maternal death and infant mortality. And as a result of that, I took it upon myself to conduct a study on this topic. Thank you very much for this opportunity.
Thank you so much. Well said. And so I had to do kind of like a little presentation on this topic. Then I'll turn it over to Dr. Amanambu. So let me share my screen. Okay, this is the topic of the day, gestational weight gain and infant mortality. Here is what I wanted to share, gestational weight gain is estimate. So what I did, I briefly looked at CDC data information regarding this topic. And they had about 46 states they tabulated gestational weight gain. And they tabulated it based on women with inadequate gestational weight gain and their percentage. Then they also put appropriate count and percentage and excessive gestational weight gain and percentage. So because of this topic is specifically focusing on Mississippi, initially Dr. Amanambu was going to do this study in Georgia. And the reason I put California in here was because I'm from California. I just want to, just for my curiosity to see where California stands. And then the United States overall, as you can see, for Mississippi, for those out of the infants that are born in the year they put this together, 21% or 22% had mothers has had inadequate weight gain. Appropriate weight gain is 29% for Mississippi, and excessive was 49%. Georgia is 26%. I'm rounding up. Appropriate weight gain for Georgia is 30%. I'm rounding up, and excessive is 45%. California, appropriate weight gain, inadequate weight gain is 21%. Appropriate weight gain is 34%, and excessive is 44%. So overall, for the United States, inadequate weight gain is 20%, appropriate is 32%, and excessive is 48%, right? So you can see that Mississippi is above the U.S. average. Georgia is below the U.S. average, and California is below. So just to give you that snapshot, I think in the year when they did this, is about 3.93 million babies, infants were born. So now if you look at the prevalence of excessive weight gain with the GeoMap, we can see where Mississippi is right here. So they are at the range of 45 to 49 or 50. California obviously is right here. I think this is Georgia. Right, yeah, this is Georgia. This is Alabama. Alabama doesn't have enough data. Then for the inadequate, California right here, they're within 20 to 25. And here is also Mississippi is similar to California. So I just wanted to give this brief synapse of what we're talking about today. This is very, very important. Actually, I missed one thing. So I think there's something I missed that's very important that I need to also discuss. In fact, that's where I would have started. Okay, yeah, this is where I was gonna start. So gestational weight gain comes with multiple risk factors, right? So there's a lot of them. But the reason I put only this particular study is because it's very, very interesting. This study was published in 2021. It's maternal pre-pregnancy weight and gestational weight gain in association with autism and developmental disorder in offspring. This is not causation. This is correlation. This is well documented. And this is not about, telling women what to do. It's about responsibility. If you want to have babies, you need to understand the risks associated with pregnancy. And gestational weight gain is not different than women that are pregnant and started smoking, right? It's a risk factor. So we need to understand that, and we need to take that message back to the neighborhood to communicate with women and improve their health literacy. So this study is very, very important. I will encourage everybody to read it. It was published in 2021. It includes Department of Nutritional Science and Toxicology, University of California, Davis, UC Berkeley, included Environmental Health Investigation Branch, California Department of Public Health, Richmond. It included Dressel Autism Institute. Included Division of Research, Kaiser Permanente, Department of Behavioral Health Science, University of Pennsylvania, Department of Mental Health, Johns Hopkins, which is one of the top epidemiology school in the United States. It included Department of Epidemiology, Johns Hopkins as well, Department of Epidemiology, Gillens School of Global Health, University of North Carolina, and also finally included National Center on Birth Defect and Developmental Disability, Center for Disease Control and Prevention. So This is a very comprehensive study. So now, here is their finding. What they found is that maternal obesity class 2 and 3 was associated with autism spectrum disorder, ASD. This is the adjusted odd ratio 1.87. They went further, and developmental disorder, which is adjusted odd ratio 1.6. They also say that gestational weight gain Z-score was not associated with developmental disorder, but the gestational weight gain Z-score highest theta was associated with high odds of ASD, particularly among male children. Okay, so, and their conclusion was the result indicated that maternal pre-pregnancy severe obesity increases risk of autism spectrum and developmental disorder in children, and suggested high gestational age adjusted gestational weight gain is a risk factor for ASD in male children, because maternal BMI and gestational weight gain are routinely measured and potentially modifiable. These findings could inform early intervention for high-risk mother-child diets. So again, like I said, pregnancy, childbirthing is a responsibility. It's not a pleasure. So people need to know their risk. Especially, this will be very informative for young women and young men that are planning to have children. Know this information so that you can inform yourself better. So without further ado, sorry about this confusion about where I'm supposed to start. Unfortunately, I don't know why this slide didn't go the way it's supposed to go. I will turn it over to Dr. Amanambu to start his presentation. So, Dr. Amanambu, before you start the presentation, I will start posing questions on area I want you to focus to do this presentation, which will be, I would like you please to discuss the problem, the background, purpose, and significance of your study, and why you conducted this study. And if you can start us with that, we go down the list as we go to get to your finding and see what we learn from your study.
Okay, thank you, Dr. Bello. Let me try to share my screen here.
Go ahead.
Yeah, Mississippi has a disproportional high infant mortality rate when compared to other regions of the country. Recent research have indicated that a high proportion of African-American women are either poor or within low economic, socioeconomic status category, which tends to affect African-American women's safety, nutrition, choices, educational attainment, well-being, access to prenatal care, and overall health care. Further research is needed to understand why Mississippi has a high incidence of infant mortality rate. The odds of a infant death are higher among obese women. Obesity is a risk factor likely to increase in women with greater maternal weight or BMI during pregnancy. The proportionality of infant mortality among African-American women in Mississippi indicate that further epidemiological studies are needed to explore the risk and burden associated with this adverse health outcome, as well as potential links with measures of gestational weight gain. In summary, I sought to reveal the practice of association between gestational weight gain, pre-pregnancy BMI, and infant mortality. I will take time to explain this table. This is from the Institute of Medicine, I think 2009. If you look at, there are three basic categories other than obesity of pre-pregnancy BMI. BMI is a calculation. If you look at that first column, is the weight in kilograms divided by, divided by height squared. That's the calculation. So under that column, you have underweight in terms of BMI, you have normal weight, which is between 18.5 to 24.9 kgm squared. Overweight is between 25 to 29.9. and obese is anything greater than 30. So you can see the second column tells about total weight gain. And then the last column is the rate of weight gain in the second and third trimester. And these are advisable that women don't gain more than what is required per section. Right here, if you look at overweight, it is within 0.6 in terms of the weight gain, and obesity is within that 0.5. So these are the guidelines in terms of weight gain, gestational weight gain during pregnancy. In 2016,
Okay.
yeah, well, the essence is to examine the association between the gestational weight gain. This is the parameter for the average maternal weight gain, level of education, income, and infant mortality, especially among African Americans with normal pre-pregnancy body weight who are between ages 30 to 47 years old in Mississippi. Mississippi infant mortality death was 372 deaths per 100,000 live births, and infant mortality rate was at 8.6. This was in 2017. In addition, this 8.6 infant mortality rate in Mississippi represent a 0.65% decrease from that of 2015 rate of 9.2. Despite this decrease, Mississippi was ranked the 50th in the nation for infant mortality. The odds of infant death are higher among obese women. Obesity is a risk factor likely to increase in women with greater maternal weight or BMI during pregnancy. The disproportionality of infant mortality among African Americans in Mississippi indicates that further epidemiological studies are needed to explore the risk and burden associated with this adverse health outcome. And this is evidence-based and best practice. So it is required an informed maternal and infant health program evaluation across various local or national public health intervention. And also it enhances multifactorial positive social change through improved awareness, health promotion measures, policy-making processes, health literacy education, other related peer-driven health coach and lifestyle intervention approach to support existing health programs. The efficacious application of maternal and infant mortality, public health program or intervention will substantially lower the incidence and prevalence of infant mortality. Hence, this will enhance positive social change implications and improvements. And this in terms of reconception and then antenatal counseling, reduction of risks associated with obesity, abnormal gestational weight gain during pregnancy, and infant mortality among African American women.
Thank you, Amanambu. I mean, infant mortality is an issue, and I'm happy that we're discussing one specific risk factor, in this case, gestational weight gain. There must have been, you have explained the purpose and the background of your study. Could you take us specifically to the research questions? I know it's multiple research questions that you addressed. Can you take us one at a time on this research question? On that note, can you also discuss what type of theoretical framework you used for this study and the methodology you used in terms of whether it was a strictly quantitative study or qualitative or mixed method?
Thank you. My research is purely quantitative. The first research question is, what is the association between normal gestational weight gain and infant mortality among African American women in Mississippi who are between the ages of 30 to 47 years old when compared with women with gestational weight gain greater than 35 pounds? The second question is, what is the association between normal gestational weight gain, 25 to 30 pounds, and infant mortality among African American women in Mississippi who are between the ages of 30 to 47 years old when compared to gestational weight gain greater than 35 pounds after accounting for income? This has something to do with income, comparable as against the first one. The third is, what is the association between the level of education and infant mortality among African American with normal pregnancy weight gain who are between the ages of 30 to 47 years old in Mississippi when compared to women with gestational weight greater than 35 pounds after accounting for income? So if you look at
Dr. Amanambu, before we go to the next theoretical framework thing, can you elaborate why income is important, why you are accounting for income in this study, and why you are also accounting for education? Can you elaborate on those two variables, why it's important?
Income is important in the sense that it has something to do with being able to have adequate nutrition and good environment when we are pregnant. And level of education gives the person that is pregnant insight about pregnancy and also her duty to be able to go to various agencies or clinic to make sure that throughout the duration of the pregnancy that somebody she's monitored and well advised on what to do next. So education plays a very vital role, and also education in other words is also can become a determinant of the amount of income you are going to make.
That's actually the latter point is very interesting, and I like that because a lot of people, a lot of scholars will argue that education alone doesn't necessarily, and I will agree to that, doesn't necessarily convert to health literacy. It's not really about like, you're educated, but at the same time, in terms of becoming health literate, right? So I want our audience to understand that education is totally different from health literacy. Those are two different things. You can be educated and still not have enough information to be health literacy. And health literacy is commonly either self-taught, and also you can also acquire it through education, no doubt. But it also can be acquired through direct communication and interaction with your provider. So I just want to make those differences. So that being said, do you disagree with me, or do you agree, Dr. Amanambu?
I agree with you 100%.
Okay.
Level of education is a very important factor in terms of pregnancy.
Okay. So that being said, let's move forward to your theoretical framework.
Okay. My theoretical framework is based on eco-social construct, and this was a model established in the early 90s to apply to scientific methods such as explaining medical best practice and patient care. It basically includes three basic patient conditions at the level of biological, psychological, and social components. There are three major components that interplay in this framework. The constructs are integral in explaining optimal integration of patient outcome rather than focusing on a single component. And then this is the visual diagram of the eco-social theoretical framework. If you look at those diagrams, you see level of social and ecological level. You have individual, household, area or group, regional, national, and global. And if you look on the far left, you find that there is an embedment of hardware of embodiment, I'm sorry, accumulated interplay of exposure, sustainability, and then resistance, accountability. All these are interplaying within the individual or group. And then you look at the social ethnicity inequalities. These are social economic, socio-economic aspect of it, population distribution of health, class inequality, political, economic, and ecology, gender inequality. And these are factors that will impact on the health of a mother based on her social and economic and biological aspect of life. And this is a visual diagram integrating the three components: biological, psychological, social, with respect to the health of a mother.
So I will expand on this, want you to expand on this. In each of these diagram, biology, psychology, and social, where is your variables falling? So you remember you mentioned income, education, gestational weight gain, infant mortality. Where does your variable fall within all these?
Well, the gestational weight gain is counts into biological if you look at the in terms of physiological aspect of it.
And I will assume that the health will be part of the outcome, which in this case will deal with infant mortality.
Yes, and
because
then
all these three key areas of the biopsychosocial model, this with the outcome. What I'm trying to say, the outcome is probably in the middle. I'm not sure, but I'm trying to figure out where the infant mortality lies within this.
yeah, it has something to do with health. That's where it lies. Is social factors such as income also has an impact on infant mortality rate among African Americans in Mississippi.
Okay. Yeah. And this just to say, this model is not only specific for one racial group. This applies to any racial group: white women, Asian women, and so forth. This can apply to all.
If you look into biology, biology will go further, like into something like genetics, the nervous system, organs, psychological, social factors, etc. Okay. That is biological aspect of it. And some of those things are inheritable and you can't change them.
Okay. So let's move forward, continue with your model.
So if you look at the biological, psychological, and social aspect of it, takes into interaction of biological genetics, just as I said, social factors, family, community components to influence diseases, illnesses, health outcome. I can elaborate, but we don't have much time to look at how this can impact you in terms of your health, the biological and genetic aspect of an individual. Even the psychological aspect is also biological. Life cost perspective together with social income variation are important factors that must be considered for gestational weight gain impact on infant mortality. Socioeconomic status, the SES, means socioeconomic status, very important aspect of in terms of gestational weight impact on infant mortality. This entails income, the type of people you associate with in terms of community level, and etc. The psychosocial factors such as income also has an impact in infant mortality among African American in Mississippi. Yeah, it's purely quantitative. It allows the ability to objectively examine the association between gestational weight gain, in parentheses, 25 to 35, income, level of education, and infant mortality among this particular group of African American women in Mississippi with normal pre-pregnancy body weight who are between the ages of 30 to 37 years old in the state of Mississippi. The essence, go ahead, yeah. In this design, we are used a cross-sectional approach. This is an approach where secondary data collected from participants are used in addressing the research gap quantitatively and assess the correlation between variables of interest. It allows researchers to compare many different variables at the same time. I used secondary data from Mississippi Pre-Pregnancy Assessment Monitoring System, or called PRAMS, data from only African American women between the ages of 30 to 47 years of age. This also, in terms of my research method and design, it includes childbearing women between the age of 30 to 47 years of age in Mississippi who participated in the 2016, 2017, and 2018 Mississippi Prime survey. Prime data from Mississippi state level links birth and infant death data from 2016, 2017, and 2018 survey. The minimum sample size required for the study was calculated using G-Power software, and the minimum sample that was received or obtained required was 721 African American women. That's the sample size. So the sources of this data is from Mississippi Prime, that's their public health, and it's purely based on population data of African American women in that state.
So now, thank you for explaining your methodology. I think now we're at the point where I will ask you to start explaining your findings, your social implications of the study, which will lead us to lesson learned in your study, and then take us home by explaining to us the practical applications of your study relative to in public health, clinical setting, and community setting.
Okay. If you looking at that data analysis, descriptive data analysis, you find that in terms of maternal age, 30 to 47 years of age African American women, those that were alive based on the sample is 1,203. The dead is 52, giving a total of 1,255. And the next one is, this is in terms of infant mortality. And the next one is maternal age. And you have gestational weight gain, the parameter from that underweight to the average and obese. African American within this category is 241. And that is within the first parameter of 25 to 30 pounds, 25 to 35, which is the average is 58. And then greater than 36 pounds is 214, a total of 513 African American women in terms of gestational weight gain. Right here, gestational weight infant mortality parameter estimate African American within 30 to 47 years of age. Here we're looking at gestational weight gain, and you find that if you look at the difference, the significance is 0.717. Odd ratio is 0.754.
So basically, in your first research question, where you looked at these women ages 30 to 47, there was no statistical significance in terms of the gestational weight gain when you compare them to women that have abnormal gestational weight gain, which is greater than, I think, 26 or 25. I don't know. But okay, so there's no statistical significance.
That's correct.
Okay.
Here, this is the second research question. Here, I examine the association between normal gestational weight gain of 25 to 35 pounds and infant mortality among women in Mississippi who are between ages 30 to 47 age old when compared to women with gestational weight gain greater than 35 pounds after accounting for income. Based on the study analysis, African American women between the ages of 30 to 47 age old with gestational weight gain of 25 to 30 pounds did not significantly predict infant mortality compared to African American women of the same age group with gestational weight gain of 36 pounds or greater after accounting for income. In addition, none of the maternal income in terms of 60,000 to 85,000 was significant, And then the p-value was 996 Odd ratio is 0.0, respectively. Predicted infant mortality. Therefore, the null hypothesis was rejected, as well as this research question. This finding did not support the study, which suggests that gestational weight gain above recommended weight was related to greater risk adverse health impact for the mother and infant. In this current study, the adverse outcome of infant mortality investigated were not significantly different from the two gestational weight gain, 25 to 35 pounds versus 36 pounds or greater, as analyzed.
Okay, so for me, I'm looking at this. What this tells me, the first research question, I'm going to go over there. You did this straight raw analysis without accounting for any what we call covariate or co-founders. There's no statistical significance. You just look at straight up gestational weight gain on the raw data and analyze it, and there's nothing, no statistical significance. I'm not saying that this invalidates the research question or what you did. We're gonna talk about that later. Then on the second research question, you did the same thing you did in the first research question, but you actually accounted for income at this point. You stratified these women with this gestational weight gain based on their income. When
That's
you
correct.
do that, you actually use women with income level of 85,000, income that are greater than 85,000. Those are your reference, right?
That's
and
correct.
then the comparison was women who has income group between $0 to $60,000 a year, and women between income $60,001 to 85,000 range. So based on this finding, again, there's no statistical significance comparing women of gestational weight gain, normal gestational weight gain, compare them to those that have abnormal gestational weight gain, which is greater than 35. Okay,
Yes.
so that's the second research question. Now, let's look at the third research question.
I examined the association between the level of education and infant mortality among African American women with normal pre-pregnancy body weight who are between the ages of 30 to 47 years old in Mississippi when compared to women with gestational weight gain greater than 35 pounds after accounting for income. Primary school, high school, and college were not statistically significant. If you look at the p-value and odd ratio in predicting infant mortality among African American women 30 to 47 years of age compared to those with higher education. Also, African American women ages 30 to 47 years old with gestational weight gain 25 to 35 pounds did not significantly predict infant mortality compared to African American women of the same age group with gestational weight gain 36 pounds or greater after accounting for income. In addition, none of the maternal income, 0 to 60,000 and 60,000 to 85,000, significantly predicts infant mortality.
Okay, this is very interesting because I think we're going to dive into this, because if we don't have statistical significance, that's a good news, because now what we can do is look into what are the interventions currently going on in Mississippi that is showing this good news, right? That does not say that gestational weight gain is not a risk factor for infant mortality. That's not what it says. It says in here that in these particular instances, which could be a lot of reason why there's no statistical significance, it is not. So here you did the same thing in this research question 3. You did the same thing, the same analysis you did in research question 1 without accounting for anything. But here in research question 3, you focus on accounting for education. you use a higher education level, which I believe at this point could be master and PhD as your reference for primary school and high school and college, right? So 4 categories of education. And then you look at the same gestational weight gain group and you use those that are abnormal gestational weight gain greater or equals to 36 pounds as your reference, and you compare them. There's no statistical significance. After you stratify all these women, those that have infants that died, 52 of those infants that died, you stratify their mothers based on their educational level and their gestational weight gain, and you still didn't see any statistical significance. This is interesting. So take us home with your lesson learned.
Well, the findings of it provide assurance to local, state agencies and health programs in Mississippi currently engaging in enhanced cultural competency training on the importance of application of evidence-based intervention in public health effort, specifically on maternal and infant health. These findings indicate a positive return on investment in the application of evidence-based intervention that addresses public health needs.
So that positive, I like the fact that you put positive return on investment, because as we know, and you guys have seen the first slide I shared with the multi-academic studies where they show now that gestational weight gain is linked to autism and developmental disorder. So we know these are risk factors. And in fact, in the study, they actually recommended early intervention. So the early intervention would be, for example, if a woman, that wants to get pregnant, or if they're couple, they want to get pregnant, you need to start understanding that if you're overweight already, you need to know your range of the gestational weight gain when you're pregnant and start early intervention. It can help. That's basically what I'm understanding from here. But I'll leave it up to you to discuss also the lesson learned based on limitations and challenges.
If you look at the outcome, the research design applies a cross-sectional application. As a result, the finding infers correctional and not, it's more of correlational, not causation. In 2016, 2017, and 18 primes data set used for the data analysis were collected from CDC as surveillance data and were not tailored or intended for this specific study. And usually at times, this is done by telephone, and at times, some of these women are not tracked down. The 3-year of Mississippi prime data sets and the overall sample with the inclusion of criteria was very small.
So the sample size is very important as well, because sample size can lead us to type 1 or type 2 error. So that's a different topic. I don't know if Dr. Amanambu tested for those, but it can lead us to that. But your finding is very interesting. In terms of that, what are your practical application for what you just found? You found all the 3 research questions. When you don't account for education, no statistical significance in Mississippi, state of Mississippi. When you account for income, still no statistical significance. When you do account for education, no statistical significance. When I say no statistical significance, I mean that it's saying that gestational weight gain did not predict the infant mortality among those infants that died that were identified in the Mississippi prime data. So since you found those out, what are the practical applications for your study in terms of social change?
Well, the study was delimited to women that are between the age of 30 to 47 years, because pregnancy in this age bracket are generally considered to be higher risk of health complications. And then in terms of the clinical setting and community setting. So in terms of social change, there is an organization, I think it's a nonprofit organization in Mississippi. The name, I think I can recall, is Golden Hour Neonatal. And neonatal are infants that are that are 7-day-old in terms of birth. And also infant mortality review. This is another agency in Mississippi. Prenatal qualitative collaborative organizations offer interventions designed to improve infant and maternal health and reduce preterm birth and infant mortality. This has been going on for about the past 7 years. So based on these findings of this study, it is possible that these programs have positive social and public health implications in reducing infant mortality among African-American women in all BMI and gestational weight gain status. In addition, Mississippi Public Health Department can conduct additional assessment to explore whether the infant mortality gap among African-American and other minority race agency and white has been reduced as well. So, but my study did not go to compare other ethnic groups. My study focused on African-American. Programs such as the aforementioned agency, Golden Health Neonatal Care, Fetal Infant Mortality Review, and Mississippi Prenatal Quality Collaborative can be empowered by the findings of this study to continue to promote active participation in the programs. The following paragraphs provide a summary of this program, and I don't think we have enough time to deliberate into the success of this program in Mississippi.
So thank you so much, Dr. Amanambu. This is very, very good study that you did. Non-statistical significant in study depending on the lens through which you look at it, right? I'm looking at this as a positive thing. We know gestational weight gain is a risk factor to maternal health when they're pregnant and even infant mortality. There's something Mississippi is doing, and I think it's worthwhile for other states in the country, in the United States, or in the globe to, in fact, look into what Mississippi is doing with among these women with abnormal gestational weight gain, whereby they are having babies and, eliminating, babies are dying. But when you compare those to those that have normal weight and abnormal, the difference is there, but the difference is not sufficient enough to show a statistical significant difference, right? So this is a very good thing, and those nonprofit organizations and the Department of Public Health in Mississippi, I guess they're doing a great job doing an early intervention, because this is important in terms of going back and doing early intervention with women and making sure that, they understand this risk and take appropriate, steps to ensure that they reduce their risk of infant mortality and even maternal complication during childbirth. So that being said, I will open it up for open discussion for people to pose questions. Let me I will stop sharing so that we can, just feel free to ask questions. You can come on camera if you want. If you have questions, please be my guest and pose the question. Let me also look at the comment section and see if people pose questions in the comment section. Please don't be shy.
Okay, hello. I have a question. Just to put in perspective, you compare right now women 30 to 47 years old. What if you compare to women that are below age 30?
Well, normally, if you look at if you study maternal care and health, women between the age of 15 to around 25, they don't have much problem in terms of neonatal death or infant mortality statistically. So I elected to look at this population that are more advanced in age and are apparently probably with higher income comparable to a teenager that is going through pregnancy.
Yeah, but no difference in mortality, in infant mortality between the two groups of ages.
What ages are? Well, there should be a difference.
Take two groups, 30 to 47 compared to, I don't know, 18 to 30.
18 to 30 have lesser matter. This we are looking at, especially neonatal death, which means infant that are only 7 days old.
Yeah. Okay, it's just to compare out of curiosity. Thank you.
Thank you, sir.
And just to add to this, Daniel, for your question, remember when Dr. Amanambu started this study, he already set his mind up what he wanted to do. Compare gestational weight gain, normal gestational weight gain to abnormal, which is greater than 30, equal or greater than 36. But the key important thing is that he want to account for income.
No, I got it.
Education, right? So if you look at younger age people, the type of income he's comparing,
yes,
you will not be making that type of income on average, right? And even when you look at higher education, if you look at somebody graduating from high school at 18, going to college, graduating at 22, 23, right? Then you compare whether they got higher education, they're not within that age, right?
yeah.
So
No,
it pushes to 30 to 47, even when it's pushed into that age actually also have, you're talking about geriatric pregnancy, which
yes, I have another question connected to that, at least that it's a variable that I haven't seen, is women between 30 and 47 are maybe already pregnant for the second or third time. It's not their first infant. Has that been taken into account?
Well, I didn't take into account if it is the first pregnancy or second pregnancy. I was looking at in terms of the occurrence of that incident with respect to their age and income.
Yeah.
And social economic status.
Yes, no, I understood that. It was well explained, I think, and that. But I was just wondering the age and again number of births. Usually, I think, if I remember, a long time ago, I read that you have a high mortality for the first child, very low mortality for the second child that comes out, and again it increases. Problem increases with the third and fourth child. But this is old stuff that I read maybe 40 years ago.
Yeah, well, yeah, things have changed in terms of socio-economic status, income, educational level, etc.
Yeah. Okay. Thank you.
Thank you, sir.
Come on, guys. I know you guys have questions. Pose your question. And let's see what we got. Let me look into the chat and see. Question, comments, not just question. You can, if you have comment or supporting comment or a comment that disagree with the study, that's fine. It's all welcome. There's no question on the in the chat. Sorry.
When is the next study coming out that compares ethnic groups and that I think you announced already?
Yeah, well, the next study will probably be looking at, it's going to be intercontinental.
Oh, yeah.
Comparing the population Africa south of the Sahara with those of the population here.
Okay.
And to look at the genetic aspect of that in terms of infant mortality.
Yeah. What is your feeling? Do you think there is a genetic component?
There should be some aspect of genetic component in terms of gestational weight gain.
Yeah. But in that case, I would say, when you say sub-Saharan Africa, are you going to look at different areas of Africa?
Yes, specifically because I know that most of the African American descent come from Africa south of the Sahara.
Yeah, but yeah, I was thinking even south of the Sahara, there are probably genetic differences, if you believe that there are genetic differences.
Of course, there are in terms of population genetics.
Right. Right. If you're going to take that into account too, I don't know, between Ethiopia and I don't know, Mali or
Ethiopia is very far off from the population I'm going to study that were part of the population that were shipped during slave trade from the southern West African, like Nigeria, southern part of Ghana. Mali was also involved, the Yoruba tribe to Cuba. So this will include Cuba, the Caribbeans, and then Brazil, South America, and then North America.
Okay, thanks.
Thank you very much, sir.
Hello, good afternoon. This is Dr. Riggs. Thank you, Dr. Omelu, for this space to talk about such a topic that is extremely important, especially for the state of Mississippi. I think, too, it would be a great idea to, when we look at Mississippi, to talk about the social determinants of health as well, and why there are such poor outcomes, especially with, infant mortality and gestational weight gain. Definitely knowing that there's a biological component, and really, I think, taking a deeper dive into those social determinants of health. And it was, I think it's a great idea and factor that you talked about income, because research shows that those without a high school diploma and earning less than $15,000 specifically within that region have very poor health outcomes, and those of minority populations down there having some of the worst health outcomes. So I'm really grateful that you shed some spotlight on this study, and hopefully we can continue to take a deeper dive into some of those social determinants of health that play a factor into these outcomes.
Thank you, Dr. Rich.
Because Dr. Rich just spoke, I think, George, it'll be interesting for you and Dr. Riggs. Okay, let me go back. The people don't know who is Dr. Riggs. Dr. Riggs is an expert in qualitative study on gestational diabetes among women. She did her study in Indianapolis. And it's on YouTube now. You can go and review what amazing job she did in her study. It was amazing, one of the best qualitative study ever done. Indiana University loved the study and all that stuff. It's already published. So I think it will be interesting, since we are talking about gestational weight gain. The collab will be very, very good to collab and do a gestational weight gain and gestational diabetes together and look at women with gestational weight gain, abnormal gestational weight gain. Do they have diabetes? And what is the outcome of their infant? It will be interesting, because all this with gestational, one is gestational diabetes and one is gestational weight gain, looking at those women, selecting population of women with gestational weight gain and gestational diabetes, looking at their outcome and seeing what it is. I think this is a study that will not only inform the state in questions, but it will also inform public health, inform CDC on these two risk factors. We know gestational diabetes is a risk factor for infant health and even the mother, and gestational weight gain is also a risk factor. So it's just an idea. I'm throwing an out idea in here. And also to talk about the future study that Dr. Amanambu plans to do in sub-Sahara Africa. One thing that study would be interesting. I would like to see that. But one thing we also need to pay attention while doing that, and Dr. Riggs touched about it a little bit in terms of social determinants. We can extrapolate that social determinants and look at sub-Sahara Africa, because the prenatal care in those countries is not as advanced as it is in the United States, in most developing countries. even though there could be a predictor factor of gestational weight gain, the good thing should be to look at the attributable impact of gestational weight gain in those countries in terms of looking at attributable impact of the whole social determinants of health, even though Dr. Ray was suggesting in Mississippi, but I will also do the same suggestion in sub-Sahara African country, because I know even West Africa, Nigeria, where I came from, have suboptimal health facility to care for maternal health, even for prenatal and antenatal. I think there's somebody that wanted to speak. I don't know whether they left the call while Dr. Reese was talking. But Dr. Reese, thank you so much for your comment. It's highly welcomed. Your suggestion is very, very important to future studies.
Well, thank you for the space. And you know, I'm definitely interested in collaborative work and efforts to you know, ensure the greater good of those who are affected. So happy to help.
Any other comments, questions, suggestions, insights, innovative ideas? We're welcome here. This is the space for this. Okay. It seems that a lot of people don't have comments. I guess they're satisfied with the presentation and the questions that are already being asked. Thank you, everyone, for coming in, taking some time out to join us in this podcast. Appreciate all your time. What I would advise people to do is whatever you've learned from this podcast today about gestational weight gain, please communicate that information to your loved ones, communicate that information to your colleagues, communicate that information to your friends. This is important. This is not about feeling how you feel about gestational weight gain or how you feel about this or that. This is about science. This is about what we know universities has done, saw it as a risk factor for multiple things. This is what public health has done. This is what CDC has done. So we have the surveillance data that shows this. This is not about feeling. So when we talk about science, let's take our feeling outside of the equation and look at the raw objective data and make informed decision. That's why I opened this platform called Public to have all this type of discussion in a constructive manner that will inform people in what they do and their decisions in life. Thank you, everyone. This podcast is gonna be on YouTube either tomorrow or Monday. So if you have not already subscribed to Public YouTube channel, please subscribe to the channel to support us on what we do. And once it's posted, you will get an alert that this video has been posted. And then you can also take that opportunity to be an active participant, active in the sense that you get information that will be useful to somebody else. What do you do with that information? You share it. Sometimes the information is not for you. It could be for somebody that needed it. And you don't know when you save life, when you share such information. And once again, thank you, Dr. Amanambu, for all your great work on this gestational weight gain. I'll be looking forward for the next study you'll be doing, and to also invite you back in this platform podcast, a Public podcast, to share that information. Without further ado, I will turn it over to you if you have any conclusion statement, Dr. Amanambu, to provide to close this out. Thank you.
Thank you, Dr. Melo. I'm very grateful that you provided this opportunity for me to present my findings and also to interact with my colleagues. And I say I appreciate my wife being one of the people that is watching me today. Thank you very much, Adago, for being present. And I'm looking forward to working with you in terms of my proposal, looking at intercontinental studies with respect to African American in terms of gestational weight gain or in terms of genetic aspect of childbirth. Thank you very much.
Thank you, everyone, and thank you.
Thank you.
Looking forward to the new study.
Thanks.
Merci.